Good afternoon, good morning, and good evening, everyone. Thank you so much for making the time to join us on this fourth webinar in the TB genomics series that we've been having. And we've really organized this series to be able to improve our understanding of the policy and technical requirements for implementing targeted next generation sequencing and facilitate collaboration and knowledge sharing among countries. And we've really gone through the global landscape as well as country experiences that we started with Eswatini last month, sorry. So we're really excited this month that we have Dr. Viegas with us from Mozambique. But before I introduce her, I'd like to just give us a few housekeeping announcements. You will see that you have access to you have access to the chat box, but you were unable to post in there. But you can post your questions in the Q&A box. There is also interpretation available in French and in Portuguese. So you can select the channel you want to be in by clicking on the globe icon on your Zoom toolbar, and you can select the appropriate channel and remain in there to receive translation that will be occurring simultaneously. You'll also be able to then we'll then ask the questions that you post in the Q&A box during the discussion session. And if we don't get through all the questions that you post today, we will also be able to send them over to Dr. Viegas, who will be able to provide those responses. But on the line, we also have Tatiana and Nalia, who are going to be assisting Dr. Viegas to answer some of the questions in case we don't get through all of them during the discussion section. If you need a certificate of attendance, that will be posted to you after, a link will be provided after the presentation, and you can click on that and get access to your certificate. We'll also provide the slides and the video of this session after the presentation, and that will be sent through via email with a link to those materials. So we're really excited, as I mentioned, that we have Dr. Sofia Viegas from Instituto Nacional de Saúde, and I tried to pronounce this, but I know I've said it wrong, but it's National Institutes of Health in Mozambique. So Dr. Viegas is a biologist. She graduated from the Eduardo Mondlane University in Maputo, Mozambique, and she has a doctorate in medical sciences from the Karolinska Institute in Sweden, where she focused on molecular epidemiology of tuberculosis in Mozambique. She currently is the Deputy General Director at the National Institute of Health in Mozambique, and she has played leadership roles as Director of the Public Health Labs of Mozambique, as Director of Public Health Labs from 2019 to 2023, and Head of Department of the Lab Reference Services from 2015 to 2019, all at the National Institute of Health. During the COVID-19 pandemic, she was the head of the lab component of the national response in Mozambique. And throughout her career, she has led efforts in the field of tuberculosis, public health, and lab diagnostics with the aim of strengthening health systems in Mozambique. So we're really excited that Dr. Viegas accepted our invitation to come and present today. And over to you, Doc. Thank you so much.
Thank you so much, Dr. Lucy, and thank you, ASLM, for inviting me. It's an honor to be part of this important ECHO session, and I hope I can contribute and share some of the work that we are doing in Mozambique in this regard. And I must say, Dr. Lucy, that the pronunciation of Instituto Nacional de Saúde in Portuguese was perfect. So I will then share my slides. Thank you once again. So Dr. Lucy made already a presentation of myself. So my name is Sofia Viegas, and beside the Deputy General Director at INS, I'm also a researcher in the field of tuberculosis and also lab diagnostics. And the topic I have to share with you today is a really important one on the urgent need for rapid detection of bedaquiline-resistant TB. Maybe also, before I start, acknowledge the presence of Nalia and Tatiana and the team from INS. Thank you so much for organizing this meeting and for your support. So this is the outline of my presentation. I will start briefly talking about INS, the Instituto Nacional de Saúde, or the National Institute of Health. I will also talk about the TB epidemic in Mozambique, about bedaquiline, and then the pathway to implement sequencing in our country. And we will also share some results of a research project that we are conducting. We will share some results that were published already and some preliminary results of the work we are doing. And finally, we'll move to next steps and concluding remarks. So about INS. So we are the Public Health Institute in Mozambique with the main mandate to generate evidence to inform policy-making decisions in the health sector in Mozambique. We became fully autonomous in 2017, turning into the national authorities for activities related to the generation of evidence in health in Mozambique. On the left picture is our headquarters in Mozambique, in Marraquém. And on the right is just to show you our representation around the country. So we have representations through INS offices, or let me see if I can point. Yes, through INS offices or public health labs or research centers in all provinces of Mozambique. So our responsibilities within the health system includes clinical and biomedical research, laboratory reference services and systems, surveillance, emergency response and health observation, also health communication, training in public health, and finally, partnership with international and national institutions for research, education, and public health activities. So, regarding the TB epidemic in Mozambique, in 2011, TB was declared a national emergency in country. And Mozambique is also a high TB burden country for TB, for MDR TB, and for TB and HIV co-infection. And our TB incidence is 361 per 100,000 population. And we have a case notification rate of around 116,000. And notified of cases of resistant TB in 2023 were 4,200. We do have a high prevalence of MDR resistant TB of 3% in new cases and around 12.5 in previously treated cases. And we have bacteriological confirmed cases that were tested for rifampicin resistance, a percentage of 85%. In terms of equipment available in country, we have a little bit 242 gene expert equipments, 30 food TrueNet equipments, 36 of the gene, 36 of them are 10 colors, so among the gene expert ones. And we have 5 culture labs distributed in the country. So regarding bedaquiline, so bedaquiline has revolutionized MDR and XDR care. It's now part of all oral regimens recommended by the WHO and is being widely used across high-burden countries. But with the expanded use comes inevitable pressure for resistance. So we are now seeing more mutations in key genes like the RV0678 that confers resistance to bedaquiline. And these often also lead to cross-resistance to clofazimine. However, because phenotypic testing is slow and not widely available, the true scale of resistance is likely underestimated. So we have a diagnostic gap. We don't have yet a WHO endorsed rapid molecular assay for bedaquiline resistance. As I mentioned, whole genome sequencing and midget-based DSTs are limited by infrastructure and takes time. And the absence of point-of-care diagnostics impairs timely resistance detection and regimen captation. So the question is, can target next generation sequencing be a solution? So with that, I will now move to the pathway of implementing sequencing in Mozambique. So this started in 2017 with a research project that we were conducting with colleagues from Munich University. And during that project, we identified the potential need for sequencing in Mozambique. So we wrote, we concept the project on target NGS and whole genome sequencing in 2019. We had several trainings, capacity building, supervisions for CTAB DNA extraction. So CTAB and the target DNA extraction. In 2021, 2022, we didn't have yet the capacity for whole genome sequencing. So we sequence our samples in Borstal Research Center, while we were creating capacity in country. That was finally created in 2023. And the same year, we published the data that was analyzed and sequenced in Borstal. And we published in Lancet Infectious Diseases the set of data that was analyzed. I will go through that afterwards. And then we identified the need of writing a pilot study to see the feasibility of implementing sequencing in Mozambique. And we did that last year, and we are planning to implement the pilot this year. These are just some pictures of the different moments that we had through all these years. We also brought one slide to show you the capacity that was created before and after COVID. So before COVID, we had this target sequencing equipment for sequencing, and after COVID, this is what we have now. We have several equipments installed at present at INS headquarters, but we do have other two equipments that are installed in the provinces, in two provinces, in two regional public health labs, and they are being trained also to start sequencing. Those regional labs, they also have TB reference labs. So, and I must say that when we started with one of these ones, so with iSeq 100, and during COVID, when we had I don't know, you probably remember when we had the emergency of Omicron in the South region of Africa, so in Southern Africa. So we had the urgent need to sequence for COVID as well. So this equipment that was initially hired for TB have supported COVID surveillance at that time and still supporting. So we are using in a multi-disease approach. And this is the framework for next generation sequencing implementation in the national health system in Mozambique. Uh, Pillar one, policy and governance. So we need to advocate the value of TB genomics with policymakers and bringing genomics into the national disease control strategies. For this, we use evidence-based research on TB resistant. I will show you some of our results. And this is important to promote and advocate the importance of TB genomics in public health systems. Pillar two, creating a technical working group and clinical committee. So this is important to guarantee that all strategic actions and plans are accomplished within the framework. And the clinical committee, of course, to define the appropriate treatment regimen for that patient. And then integrate this into the TB control programs, strengthen TB sequencing workflows, improve data management and sharing, and finally translate TB genomics for patient management and public health actions. And this is just a reflection of the implementation of the framework. So some pictures of the capacity buildings that we had, a meeting with the stakeholders in Mozambique, the National TB Control Program that took place 3 years ago. And then we did a workshop to discuss which would be the best workflow, how we are going to implement this, some pictures of the different trainings. And then we discussed with the NTP the pilot study and the algorithm to be implemented in the country. And finally, we wrote the pilot, and we are waiting for the ethical approval to start. So this is just to say that this is not only lonely strategy. We have integrated the TB genomics into a national integrated approach, One Health approach. And I will not go through all of the areas, but you can read. But it includes, of course, agriculture, health, and environment. So it's a One Health approach for integrated genomics. So, and we are advocating for evidence-based implementation. And for that, we had the research, the paper that was published. Before publishing, several discussions and presentations took place with the NTP and stakeholders. We publish, and we are now also disseminating the results. We are running a surveillance program for whole genome sequencing and target generation sequencing, and then the pilot that I have described, that I have mentioned before. Now, moving to the paper, to the article that we published. So on top is the title of the article, Emergence of bedaquiline-resistant tuberculosis and multi-drug resistance and extensively drug-resistant M tuberculosis strains with the RPOB ILE491FHE mutation not detected by gene expert in Mozambique. It's quite a long title. I will only focus on the main findings during this presentation. And this was written together with colleagues from the Borstal Research Center, of course, colleagues from INS and from the NTP in Mozambique. So this is one of the main findings of our paper. So if you look here, oops, the legend is out. No, not here. So if you look here, so in blue we have bedaquiline resistance. In purple, bedaquiline resistance without RPOB mutation. In dark blue, bedaquiline resistance with RPOB mutation. And here in red is fluoroquinolone resistance. So what we want to show here, so if we look at the bedaquiline resistance, it is increasing over time. We did this study from 2016 to 2021. And we used samples that isolates that were in our biobank, and we sequenced them, the ones that were that we could recover and we could extract and have good quality DNA. So and this is the results that we got. So if going back to the bedaquiline resistance, so bedaquiline resistance raised from 3 to 14% from 2016 to 2021. And the fluoroquinolone resistance, in average, it was 23% during the entire period. But what we want to show here is that bedaquiline resistance was spreading independently of fluoroquinolone resistance. And we also found a high proportion of bedaquiline resistance with the RPOB with IFO915 mutation, and also with no mutation. I will talk a little bit about this mutation in the next slide. I imagine that you also listen about this with the Eswatini presentation. And here, this is a cluster analysis of the strains from Mozambique, from South Africa, and also from Eswatini. And this particular mutation that it's very common in Eswatini, it's not detected by common diagnostic methods that we have, like the Gene Expert or LPA. So they miss this mutation. It means that a patient that with this a sample with this mutation will not the resistance to rifampicin will not be detected, and so this patient will probably be treated for first line treatment, will failure, and then maybe the sample will be referred to the reference lab, and then a DST that takes time, and dissemination and contamination continues in the community. So what we found is that 31% of MDR and bedaquiline resistance, MDR and bedaquiline resistant, 31% had this mutation. And 54% of the XDRs also had this mutation. So these strains are not detected by common WHO endorsed diagnostic tools. So comparing our results, our strains with the ones from South Africa Eswatini, we found similarities indicating that there is spread between countries, but that needs to be further analyzed and with more evidence and more analysis. So comparing, if we look, the column 2 are the results from the paper that I just described, and the column 3 are from recent data that we are analyzing. So, and the first one, we have lineage 1, TB lineage 1, which is East African Indian, lineage 2, Beijing family strains, 3, Central Asian strains, lineage 4, Latin American Mediterranean LAM strains, and then the iPhone 915 mutation. So for lineage 1, we see that there is an increment in prevalence. So we can see more East African Indian now. For lineage 2, we didn't do any deep statistical analysis to see if this is significant or not. This is just the preliminary numbers that we are sharing with you. For lineage 2, we found that it was reduced from 22 to 13%, lineage 3 from 3 to 5%, and lineage 4 from it maintained, let's say, from 66 to 64%. And we found a decrease of the I415 mutation in general from 4 to 2%. And I marked in yellow the bedaquiline-resistant. Regarding, in particular, to bedaquiline-resistant, we found higher bedaquiline resistance in RIF-resistant TB from 7 to 14.3%, in MDR from 7 to 17.5%, in XDR more or less the same, with RPOB mutation more or less the same. This is just to show you that the importance of keep doing surveillance and monitoring resistance over time. Although the N is it's different, of course, we are still working on this and making sure that we have also more isolates to sequence. So regarding the BPOL regimen and the drugs that are used, we are also bringing some results showing high resistance to MOXIE, bedaquiline, I mentioned already, linosenide, and also high resistance of levofloxacin. We also brought some shocking results from Mozambique. These are young patients from 35, 32, and 30 years old, 1 female and 2 males. They are all from the south region of the country, the province of Inhambane, Maputo, and these 2 from Maputo province. And this one is only is susceptible to linosenide. This one is resistant to all drugs, and this one also resistant to all drugs. So we have patients that really have some shocking results, and it's really important to implement rapid diagnostic measures to make sure that we can detect this earlier to try to find the appropriate treatment. So this is just the flow chart of the pilot study. So we are planning to implement this in Maputo City and Maputo Province, and we have picked health units with a high volume of MDR. Those, not all of them, they have access to a gene expert 10 colors. So those samples will be referred to a site with a gene expert 10 colors, will be tested, and the ones with the RIF or ISO resistant will be shipped to the NTRL for target sequencing. After target sequencing, the results will be discussed in the clinical working group, and the results and the proposed treatment will be sent back to the health facility. And we are going to measure all indicators, turnaround time, etc., and challenges during this pilot implementation. So in terms of next steps, based on the results I showed, there is an urgent need to implement target NGS in Mozambique. We want to do it on evidence-based. That's why we want we wrote the pilot and we want to implement it. But we still have some challenges. Challenges include bioinformatics. So we need to strengthen the current whole genome sequencing analysis. For the surveillance, we need to expand sample collection and referral from other TB culture labs. We found that most, although I didn't show that, most of our results are from the south region of the country. We need to have more country representation in the central and north regions. We need to finalize the MTB complex sequencing implementation framework from Mozambique. I showed you, but we didn't approve yet. And we do have a plan to construct a bioinformatics center at INS headquarters. So we can have the appropriate infrastructure and tools for sequencing, not only for TB, but using the broader approach, integrated approach. To conclude, I brought some remarks for country next generation sequencing implementation. So it's important to build institutional capacity, but it's a long journey, but it's rewarding. So we started in 2017, but we can see the results now that are bringing more knowledge, more evidence to the NTP and to the stakeholders. Well-equipped sequencing laboratory with trained personnel is crucial. Of course, we have to train and retrain. I don't know how many trainings we had in bioinformatics, but we still have to improve, and so this is a continuous process. For us, strategic partnerships are essential for success. We have the support from Borstel, we have the support from Africa CDC, from World Bank, from other institutions that gave us assistance and supported us whenever we needed. Of course, we need scientific evidence to understand the country epidemiology, and it's important to engage the NTP and other stakeholders through the process to make sure that we are raising awareness to drive actions. Otherwise, it's just data that stays there. And adopting an integrated approach ensures long-term sustainability. We are in an area, in a time period where we need to think about resources, financing, and making sure that we are creating a sustainable approach. It's crucial. So finally, this is an invitation for our session. We are organizing a parallel session in the Mozambique scientific meeting. We have this meeting from 3 years. And it's the biggest meeting in Mozambique in science, in health. And we are going to have a parallel session on advancements of next generation sequencing for tuberculosis diagnostics and management in Mozambique. It can be attended virtually or in person. So you are all invited to visit Mozambique and INS. So this is just to thank my team and also the team from Borstel that has been with us since the beginning of this implementation, and also several other partners and institutions that work with us. Thank you very much. Kanimambo, obrigada.
Dr. Viegas, that was really a brilliant presentation. Thank you so much. And I think you've highlighted the issue quite well, that we have had this new drug for possibly just over 10 years now, but we're starting to see this increasing resistance. I think many of us will remember a time when treatment for drug-resistant TB was 24 months, and people were getting deaf because the drugs were just really toxic, but those were the only options we have. So we need to preserve these new drugs that we now have. And if we keep seeing this increasing resistance, then that means those drugs will become ineffective. And then treatment for XDR has really poor treatment outcomes because we really don't have that many options at that point to give to patients. So we're really grateful that you could share your experience with us. And I already see a couple of questions that are coming in, and we'll start off with Guy, who really hits the nail on the head by asking, why did we introduce new drugs without the tools for monitoring resistance? And he also had earlier on asked when Mozambique started using bedaquiline. Over.
Yes, the first one is really important. So why starting new drugs without having the tools to monitor? So it's I would say of course we shouldn't do it. It should be the other way around. But I believe it's an enormous pressure for the NTP and for the stakeholders to implement. And this is what happens. We cannot monitor. But of course, this is something that the countries have to work on and make sure that those things go in parallel. So you cannot introduce without having the tools to monitor. But sometimes due to pressure and it can be one of the reasons why it is implemented, but it shouldn't be. The other question was regarding
when did you start implementing bedaquiline for treatment of drug-resistant TB in Mozambique?
In Mozambique was in 2022.
All right.
That we started the rollout, the rollout implementation.
Okay. And this follow-up question, I hope it's a he, I'm sorry if I say he. Their follow-up question is they want to know how to explain the presence of bedaquiline resistance without RPOB resistance, without the RPOB mutation you mentioned. I think referring to that graph you had earlier that was showing uh, the resistance was still increasing if with or without the RPOB mutation.
Okay, that was not RPOB. Well, it's RPOB IFO91F mutation. It's the Eswatini mutation. So we can have strains that are bedaquiline resistant with that mutation or without that mutation. So with that mutation, they are not detected by GeneXpert or LPAs. And without that mutation, it can be detected by current diagnostic tools
Uh,
that we have rolled out.
that's yeah, that's a good clarification to make because I see Giuliano had also had a similar question, and
No, yeah, that's a gene that it's particular for TB, but it's the I4915. Maybe when I was explaining, I didn't clarify that.
Okay. No, thank you so much. I also see a comment saying thank you for the invitation. So I think you see a lot of new registrations. I don't know if you can put in the chat the link to that conference or meeting so people can register.
Yes,
And
I
then
think registration still open.
yeah.
So Nalia and Tatiana, can you check if you have the link for registration? So yes.
All right. And then below says the rate of resistance of new drugs is really fast. Do you think that the new regimens are vulnerable? And someone also had a follow-up question to ask if you conducted resistance testing for pretonamide.
Okay, so raising our resistance. Yes, this is very scary. But I must say that this is not in for all TB cases. This is a particular group of patients that are referred and are sent to the NTRL. So they are failures, relapse, MDR suspects. So those are patients that already they are not first line diagnostics. So it's only if they are or with resistance or failure or relapse cases or MDR uh, contacts. Lucy, what was the follow-up question, please?
About pretonamide, did you do any resistance profiling for that? We, I
We
guess
did.
I think they want to see if there was any correlation with the increasing bedaquiline resistance. Were you also seeing similar on pretonamide?
We did. I wanted to show you. Can we go to the follow-up question while if there is any?
And the second question is, what is the mechanism for program sustainability and financing?
Okay. I was trying to find the graph where I have pretonamide. So regarding the program financing, so yeah, we are now writing a roadmap for an integrated approach. We believe that having this integrated approach will be a sustainability strategy. Because if you have an integrated approach, you might have resources for one particular surveillance program that can also support the others. The referral system can be integrated as well. So having this integrated approach, we believe can be a strategy for sustainability. But within that framework that we are working, we will also include a chapter for sustainability. So making sure that everybody that works with us, they are aware that this is an integrated approach. When I mean integrated, it's not it's One Health, of course, but also based on several pathogens and initiatives. So we believe this can be a possible solution for this. And also the bioinformatics center that we are building will not only support health-related bioinformatics needs, but also for needs in the environmental area, or needs in the animal component as well. So we are building a bioinformatics center that will serve all the country. So we think this can be helpful as well. Can you hear me?
Yes, I can hear you. So I think Lucy is getting back shortly. So let me just support as she's sorting out something quick. Thank you again, Sophia. And there is a question that is coming in, and I wanted you to deal with this as well. And it speaks to where you're placing your tNGS referral levels and what the turnaround time is for your results.
Sorry, can you repeat the turnaround time?
Yeah, so what is the turnaround time for results for your tNGS? When the samples are received in the lab, how long does it take to get out the results to the care team?
Yeah, we now have a quite long turnaround time. We have established that the turnaround time should be 1 week for target sequencing, and we are taking double the time. So we need to work on to really reduce the time for sequencing, in particular for target NGS, because we want to implement this in the pilot. We want to use it at country level for patient management. Now we are only using for surveillance. I would say it's okay, but for patient management, we have established a maximum time of 1 week. So we are working to really monitor this and make sure that we are not extrapolating 1 week.
Great. And just to follow up on that line again, especially with the TAT, but now looking at the platforms that you're using, what considerations did you make in selecting the platforms that you're currently using to do your sequencing?
What considerations? Well, initially, so we take several things in count, including the number of we have small equipments that can only do target sequencing for TB, but we need bigger equipments with more capacity for whole genome sequencing of TB. So it depends on the capacity of the equipment. Of course, the bigger equipments, they are more expensive for maintain. The reagents are also more expensive. So we need to make a balance. But we also consider the country assistance when we got the Illumina equipments. So those are we didn't have in country yet support. Actually, the support was coming through Portugal, but now we have the support in Mozambique. So this is something important to make sure that we have support to run and to maintain those equipments. Most of those equipments were also donated, although we could we were able to discuss and identify the best that we wanted. Most of them were donated, and not always we had the space to really negotiate and choose the ones, but most of the times we could also say no. There are some equipments that we said no, we don't want, we don't want for now. But most of them were also during COVID. We got them during COVID, and we had, so we were running a public health emergency, so we needed the equipment. But I would say basically the capacity of the equipment, and also local assistance, and having,
Great.
of course,
So,
the protocols the protocols to run the equipment.
okay, great. So we have our next question is coming in from Guy, and Guy is asking, I think, two quick questions. The first is, what do you think could be explaining the fact that you had bedaquiline resistance even before you started implementing? Because I think you started in 2022, but the data that you're sharing is indicating that even as of 2016, there was already resistance from the biorepository samples that you picked and did the analysis on. And so he's asking, what could explain that?
Yes, this is a question that we also made when we were writing the article. So we have several borders around, and there is a lot of migration between countries, and although we don't have, this needs further investigation, but we believe that it was imported from other countries. So, but of course, this needs further investigations that we're already using bedaquiline.
Thank you. Thank you very much for that question. And also thank you to your team that are dealing with some of the questions already in the Q&A space. There is a question on the formulation of the drugs that you're currently using to treat the XDR-TB, and especially those that have bedaquiline. So the question is, are those drugs as single formulations, or you have some combinations that include bedaquiline in the same pill that clients are taking?
I'm not sure. Tatiana, do you have the answer for this?
Sorry. Can you come again?
So the question is, we know that in the drug formulations, you can have single drugs in their individual pills, but you also can have combinations that put more than a drug in one pill. And so the question is, for the bedaquiline that you're using, do you have single drug formulations, or you have combinations in the same pill that you're giving to your clients?
Sorry, I'm not sure of this question. Sorry.
Yeah, I'm afraid we don't have the immediately answer, but we can find out with the NTP and come back to you.
Great, thank you. And then as we tend towards the end, I think there is a question on, do you see improvement in treatment outcomes when you're using now bedaquiline compared to the drugs that you were using before? Or that data is not yet available given the time that you've been using this medication?
Yeah, we would need to have more evidence on this. we assume yes, but we don't have data to support this. So we don't know. But perhaps a longitudinal study to evaluate how this implementation is going.
Great, thank you very much, team from Mozambique. And I'll just leave it to you now to give us some of your reflections and closing remarks with regard to the experience you're seeing in implementing this, and especially the molecular surveillance that you're doing to inform care for our patients. So just your general reflections and closing remarks, and I'll start with you, Sophia.
Yes, thank you. So I still have to, we can also answer the question regarding protonamide. There was a question on protonamide. I don't know if it was answered in the chat, but if not, we can check and answer later, also due to time. So I would say that with these scaring results that we are seeing and this emergency resistance of bedaquiline and this Y491Fi mutation, it's really, really important that we have the tools to quickly identify those patients and make sure the clinicians are putting them on treatment. And for now, the tool that we have is target and next generation sequencing. And based on the experience from Eswatini, the one that we are going to pilot now, I believe this is a solution that can support those patients and make sure that they have the appropriate care that they need. So, and it's important, of course, to have also rapid diagnostic tests for bedaquiline, but while we don't have, and while we don't, it's not figured out a test that can also detect this particular mutation, Eswatini mutation. The solution that we have is target NGS. So I think that's the way forward. And I hope next time we will be able to come and share the results of our pilots with everyone. And I hope that can also inspire others.
Excellent, Dr. Safia and the team from Mozambique there. And just like you've indicated, yes, we can't wait for tools that are not yet available to do what we have to do now. So we have to work with what we have now and hope that we get more tools to support us with the challenges that we face in dealing with this space that we currently occupy. And I know that there is also a comment on whether some of the mutations that are currently popping up, if they will be built into the future technologies. And I know that the industry partners are definitely watching all the spaces, and that's why such data are very important, so that then they can move it on to developing some of the solutions that we can utilize to address these challenges. So again, thank you very much, Team Mozambique, for sharing this very enriching experience. And we definitely have another session that will be coming up related to this, and we hope that most of you will be there to listen in. So from us, ASLM, and everyone else, thank you for joining, and do have the best of your day, wherever you're joining us from.